that we think about when we think of opioid use disorder, because it is a very wide, broad group of people who get to live this life of opioid use disorder where they have completely lost control, they deal with cravings, they are compelled, it's not a choice, it's a like mandate somewhere hijacked in their brain, they're seeking, they're using, they're not living the life that they ever imagined that they would live. But when you break it down, it's kind of like it's not just a bunch of 20-year-old men who suffer from opioid use disorder. It's not just pregnant women, who is a very special population. It's not just 40-year-old women who got started on opioids for fibromyalgia. It's all these people and adolescents. So that's my hope today, is to kind of shed a little bit of light on what makes this group special. I mean, it's a group of pediatricians I'm talking to, right? So you guys think that they're special, right? Adolescents, maybe a little bit. It's important. Yeah, it's kind of that gateway to being an adult, being independent, and all the wonderful things that happen. So this is me, who you already heard about, me. I don't have any disclosures, and I have to show you this slide. There it is. I did my job. But I do have a confession more than a disclosure. Acronyms and statistics are my Achilles heel. I screw them up all the time, all right? So just bear with me and maybe help me out on a few of them. So our objectives for today is identifying who's at risk. Who's at risk for developing an opioid use disorder? Or just, we talk about opioid use disorder. For me, that's just sort of a blanket term. It's substance use disorder for me. It just happens to be opioids for this person, stimulants for that person, alcohol for this person, tobacco for somebody else. But truthfully, we have a use disorder. We have disorganized, dysfunctional behaviors that we're using a substance to make us feel like we're functional, but we're not. So at risk, I didn't say at risk for developing opioid use disorder, because we're just at risk for doing some stuff that's not going to help us on that path to being all that we can be when we grow up. So intervention strategies for those we've determined to be at risk, what can we do? So we'll go through some of that. And then treatment options for adolescents that we have identified with opioid use disorder specifically, because we do have a few tricks up our sleeves with those guys. All right, so risks for this population. When do risks occur? Okay, I'm going to start walking. When do risks occur? Because I know you guys are talking, like eating, and I'm going to make you talk with your mouth full. So when do risks occur? When might people who you see in your practice, kids, have a risk? When might one pop up?
When they're at school.
At school, yep. Prenatal, yep, totally, prenatal. So before they even get on. Another time. Injuries, yep, because we expose them to like, oh, you go through the ER, you get the requisite Lortab script, right? Right. Okay. Other risks.
Times of stress.
Times of stress, like stress within the family. Yep, totally. Any other times we might be exposed to risks? Surgery, chronic medical conditions. Yep, those are all great ones. And you didn't, like you said stuff I didn't even put on my list, so that's awesome. So prenatal, thank you for that. Infancy, toddler, young school age, adolescence, and adulthood. So basically, we can find risk anywhere. Because when we think of our ACEs, and I know you guys know all about that, which is awesome, we're thinking about things that happened before you were 18. Trauma still happens when we're older, but we're not talking about that because this is a pediatric grand rounds and not a family medicine grand rounds. But these are all the times when someone could encounter risk, something that puts you at risk for choosing an option that may not be the best choice long term for taking care of your problem. Like, okay, has anybody in this room ever said, I've had the worst day ever, I really want to go get a beer? Never, right? Never, right? So if we did that, and we did that over, so residency, that's a stress that you experience as an adult. If you did that over and over again, like, I just need this, I'm going to have another beer, I'm going to have some whiskey now, I'm going to have, like, it just kind of helps take everything away. These things crop up all the time. So being attentive to that in our patients. And your kids that you're seeing in clinic, they're being raised by adults who are therefore influencing the environment that these kids are being raised in. So having that all-encompassing, like, what is happening in the child I'm seeing right now, their life. So being aware of all these risks can come up. It's like, I don't know, running through a cactus patch barefoot. That's what life is. So prenatal exposures, I think we all are pretty aware of those. Tobacco. We've gotten pretty complacent with tobacco use in our pregnant moms. It kind of makes me crazy. Does it make anybody else crazy? Oh, it makes me so crazy. Well, that's legal. Well, yeah, so is alcohol, but we go crazy about fetal alcohol syndrome, right? Okay, same thing, tobacco. We've got issues with that, so we need to be paying attention to that. So maternal substance use, alcohol, tobacco, opioid stimulants, whatever else they may be finding out there. Prenatal environment, what about that mom if she's experiencing tons of stress herself? She's in an abusive relationship. She's not in a situation where she's able to take care of herself, so some type of neglect that's going on, or she's homeless. She hasn't eaten in 2 days. It's kind of hard to grow a kiddo and that kid get all that it needs when mama's not eating. So in the early years, a lot of these will look familiar because it's like me just renaming the ACEs, right? You guys have seen those on the ACEs questionnaires. Like somebody in the house has substance use disorder. Somebody in the house has a mental health disorder. People don't have food. They don't have a solid home to go home to. Like there's no electricity, there's no heat, there's no water, something like that. In your community, some of these, I think we call them micro traumas sometimes, although it seems pretty big to me when you're dealing in an environment where just walking down the street in the skin you're in could actually be cause for someone to beat you up. That's kind of a big trauma in my mind. Going to school, the stressors of school and being bullied by someone, lack of resources. How much is education valued in your home? It's just the place you go. It's kind of like, I don't know, it's a place where you can kind of get babysat. They'll feed you. You're out of the house for a few hours. Do we really value education? Are we concerned about that you're learning anything in school? What are you going to do with your life when you grow up? Kind of like investing in long term and not just like day-to-day survival. Tween and teen. Everything we just talked about. And then we get to pull in our peers because when we're teenagers, right, we really care about what others think about us. We really care that we fit in. We really, like, if my friends are doing it, I'm more likely to be doing it. And then intimate partner violence, because maybe somebody told their kid they could start dating before they were 35. So you've got somebody who's influencing your patient and putting them in situations that are dangerous or making them do things they don't want to do. So you guys, who's ever used an ACE screener in their clinic? All the hands are going to go up. You guys have all done it, right? Because that's what I heard. You guys are the group that are doing it with your patients. Like we all are supposed to be doing, but you guys are actually doing it. So thank you. Good job. Do you do one based on their age? Like, do you have like the one that's like mama or dad or a guardian is filling out for the little ones, and then you have the self-report for teenagers?
So we are doing a parent and a child one,
Mm-hmm.
And we were doing it for a short period of time. We've kind of taken a break to get ramped up again.
For what
yes,
you were mentioning to me?
we are doing the separate ones.
2 ones. Okay, perfect. So Center for Youth and Wellness, this may be a group you guys have heard of. I'm kind of enamored with them. It's Nadine Burke-Harris, who wrote a lovely book, who does all kinds of wonderful talks about ACEs and has a great clinic, except for now I think she's like the Surgeon General of California or something crazy like that. So this is pulled from their resources, the Teen Self-Report. Oops, it didn't make it in there. This is the one with the hyperlink. Whatever, maybe this isn't the version I thought it was. At any rate, you guys are familiar with it, you don't need to see it again. But what I like about this one isn't a matter of like, check the box. Yes, someone has touched me in an inappropriate way. Tick a box, somebody in my family has a substance use disorder. It's more of like, of these things listed, how many have I experienced? And then it has a supplemental that adds to it, like have you encountered bullying, have you encountered intimate partner violence, specifically for the teens. And I like how it has those supplemental questions. I like their format. So this isn't the one I thought it was. Shoot a monkey. All right, I'll make it work. I've had so many versions of this, it's not even funny, because I was confessing to Brian, like, it's done, here it is. Except for I did these 5 other things to it, and I didn't send you my updates. Oops. At any rate, so we've identified that we've got, that maybe we've got some concerns for this kid. They've experienced some stressors. They've got some stuff going on in their lives, so our antennae are up. So maybe we're thinking we should do some screening. We should ask some more questions. Do you guys have screening tools?
Mm-hmm.
Like assessing risk in your kids, identifying risk?
Craft.
Okay.
PHQ-9.
Okay. How about any others?
The teens, residents help us here. We don't do adolescents every day. The gaps.
orange screener also.
What's the
We do
orange
social
screener?
determinants of health.
Okay, social determinants of. Okay, good. So you guys have got some screening tools. You're pulling them out. Which one's your favorite one? What's your go-to?
For adolescents,
Mm-hmm. Okay.
And we do social determinants for everybody.
Totally what I pulled up first. Your craft. So you got those initial questions. I love that I'm telling you guys stuff you already know. We're just reinforcing right now. So you got those initial ones, and if it's all no, then make certain that you're not engaging in risky behavior by getting in a car with somebody who's doing this, because that's not good for you either. But if you answered yes to any of those part A's, then I need you to fill out the rest. So yes, craft is a great one to use. These are fun. So sometimes I just like to go online and play with stuff because I'm not busy, so I goof around online all the time. Totally lie. I just go down rabbit holes. So this one, the screening to brief intervention, NIDA has brought us this lovely screening tool. Have you guys heard of this one? Yeah. So I hadn't heard of it either, which is why I'm including it. So it's, who do we want to be? Do we want to be the patient or do we want to be the clinician? Who do we want to be? You'll be the patient? All right, yeah, that's who I picked to be first too. Like, let's see how this works out. Okay, yes, okay, I know, sure, great. All right, how many times in the past year have we used tobacco? So are we gonna go wild and crazy, or are we gonna be straight-laced? Which way do we want to go? Wild and crazy, thank you very much. All right, so how many times have we used tobacco in the past year? Daily. So weekly or more, because it's in the past year. Okay, weekly or more, we've used it. Right, how many times have we used alcohol? Weekly or more. All right, good job. We are just riding off the rails. Past year, how many times have you used marijuana?
Weekly.
Weekly wins. I'm getting a feeling here. There's a pattern. All right, in the past year, how many times have you used prescription drugs that are not prescribed to you, such as pain medicine or Adderall? Once a month. All right, we're pulling back a little bit. All right, how many times have we used illegal drugs like cocaine or ecstasy? Once or twice in the past year? All right, we're not into the club drug scene, right? That's not our poison. In the past year, how many times have you used inhalants? None. Okay, we're not into that. No, we don't do that stuff. Shh. No huffing for me. All right, in the past year, how many times have you used herbs or synthetic drugs? Ooh, bath salts. How many times have we done that? Once. Yeah, we didn't go back to that. All right, we took the survey. It's complete. Health provider, it's complete. Tell me. So it gives you guys the risk level. Like, so this, your patient filled it out, but then you get to look at it. And it kind of walks you through. Like, we got some serious problems here. Yep, we got issues. We're higher risk for developing issues. So brief intervention, there's the OARS framework, which I'll click on it and show you guys. But it's basically just like open-ended questions, allowing them time to talk to you, respond, kind of, it's talking, it's having a conversation. I love how we like over-medicalize stuff. It's like you should use the OARS format, like basically go in and talk to your patient and let them tell you their story, really what it boils down to. Letting them know that you're concerned, additional resources. So it's kind of fun. One, it's fun to fill out and see kind of what it gives you. But it also kind of points you in directions of, because one day you won't be residents anymore and you aren't going to have all the wonderful resources just right at hand. It's really fun when you go from being a resident to independent provider and you're working in a clinic and you're kind of like, where's the craft? And they're like, we don't do crafts here. What are you talking about? You may go someplace where they don't know what craft is. So knowing that there are places like this has it right there, I can open it up. Where you can pull those resources that you're used to using and educate the people in your practice. Like, these are some really good tools, and I'm going to show you how to use it, okay? So having resources like this, and like there's a face here, it's kind of like, oh my God, really? Somebody might, yeah, they might. Developmental screening at the clinic that I went to when I left residency was like, well, you kind of eyeball the kid. I'm like, really? That's what we're doing for screening? I don't think that's going to cut it, guys. Meh. So we changed it. So the OARS model, so this is just an example of, there it is, you've seen it now. Reflective listening. Right, which one of these will give me that one, I think. Nope. Probably another confession. I am not the most technologically savvy individual in the room.
So we're not saying what you're doing.
Oh, you can't see it. Oh, I'm so sorry. I did really fun stuff up here, and you didn't see any of it. Shoot a monkey. That's not fun for you guys. I had fun up here. I'm sorry you guys didn't have fun with that. But we'll fix that. So I'm just going to go out. Do we want to? Because it's on here, but that's stuck there.
Second monitor. Where's your web?
I don't know. Oh, yeah. Remember what I said? I sort of suck at this technology stuff.
Second monitor. So.
Oh, look at that. Huh.
Doesn't help you, though.
No, because I can't see it here. Okay. Okay, so this is what I was just reading through. So you just kind of click and go through. I'm not going to do the whole thing again because, we already had fun with it, and I'm sorry you didn't get to see it. That sucks. But I will have this available for you guys to go through, and you can play with it yourself, so you can get the links for it. Okay. You need to come back and help me again, Brian. Because this actually is the one. This is the one because it's got that. So if you could, this is, I don't know. Can you open that up?
Open the link.
Yeah, no, this. Can you get this to be up there? Apparently we should have had a dress rehearsal. Okay, cool. So a lot of that, what I just went through, was harm reduction type of stuff. You guys familiar with the term harm reduction? So harm reduction basically is kind of like somebody's doing something, you're not really crazy about it. Kind of like, I wish, like you've got a 16-year-old in your office and they're smoking cigarettes. What do you counsel that patient? What do you tell them? What do you say? Hey, you're smoking cigarettes. Keep doing that. That's great. That's awesome. You're going to get so many friends and dates that way. Is that what you tell them? What do you tell them?
Like the cosmetic problems. I feel like kids care about the wrinkles, like teeth.
So it's like it's going to make you ugly and look old real fast.
Like with girls.
Why are they smoking? How do they get to cigarettes?
Okay. So some information like why are you doing it? So if it's kind of like because the friends I'm hanging around, they're smoking and they give them to me, that could very well be an answer. And then providing them with information about like, do you realize it can make you age faster, make you, like all these things that it could do to you. Do you realize the health risks that you have by smoking cigarettes? So yes, definitely. What if they tell you something about like, I just get really stressed. It's my nerves. What do you say then?
Well, behavioral intervention would help in that case to kind of teach them healthier ways to cope with stress and how to deal with stress and adjust to changing environment, and lots of times it's a social, immediate home and school. So basically teaching them some of those skills when they're teens. Like you said, we're supposed to in the clinic and we have Dr. Oliver and so he
You got all these
helps
great
out.
resources. So they're all out that day. They're at a conference, and you're like, great. I don't have anybody to talk to this patient for me about like behavioral interventions for this. So how many cigarettes are you smoking a day? I smoke half a pack. Well, I don't want you to smoke anymore. Can you stop doing that?
We can
Yeah.
help with nicotine patches and prescribe those through vendor insurance, and we can explain how to use them. And depending on how many cigarettes they smoke, they get a certain dose,
No.
and then
Yep.
we can start weaning them off.
So some of the stuff we're talking about right now is harm reduction. Because telling somebody is like, you need to quit, doing that is bad. Okay. How about we get you to cut back? How about we get you some behavioral health support to start making those changes so you can cut back and you've got something else to address all the stuff you got going on. Or they come back and they're still smoking a half a pack and you've done some of that discussion. What's some harm reduction you can do around that? Well, I'm glad you're not smoking more, right? So you reward them for what they're doing well, which is you didn't start smoking more, and you had that really hard test, and you didn't smoke more cigarettes. So that's kind of getting at the harm reduction model. Our patients don't always do what we want them to do. maybe most of the time, they don't do what we want them to do. But if they're trying or they're not moving forward in something that we find dangerous or concerning, or they're making efforts to cut back but we're not quit yet, those are all harm reduction strategies. Okay? So things about like, what risks are you exposed to? Are you testing positive for those, like you've got some risky behaviors? How do I intervene with you on those risky behaviors? Talking to somebody who cares. And that's us, right? When we talk to somebody who cares, somebody who's interested, I like the term mitigation. You're mitigating these risks. They know somebody cares. They know somebody's invested. They know they can come back to you and talk to you more. So this is, just because I like the quote, it comes from an interesting paper, Opioids Affect the Fetal Brain, Reframing the Detoxification Debate, from this summer, looking at kiddos who were opioid exposed, like neonates, and their MRI scans and just some of the changes you can see in the opioid exposed versus the non-opioid exposed brain. But knowledge of how these opioid-induced brain effects can be mitigated is key to developing an approach to clinical care. So we're talking about opioid use disorder in adolescence, right? So we've got an opioid-exposed brain. Granted, this came out of a neonatal study, but opioids do have impact on the brain and how it functions. So if a kid has been exposed, because we identified that as one of our risks, right? Kid was exposed in utero to substances. That's going to have an impact on how this kid's brain is developing. So maybe we have a predisposition, genetically speaking, because there's like, you know, all the way back to great-great-grandpappy, you know, we've been drinking or doing this or doing that. And then we put our child into an environment where food security is plus or minus, depending on the day of the week, and somebody has schizophrenia in the home, and mom is in jail, and you're being raised by your grandma who smokes like a freight train. So you can see how this stuff starts to add up and have an impact on your kids, right? I wish I was describing not the usual, but how many of your patients does that kind of describe? Yeah, a fair number of them. So thinking about, like, this stuff has happened. There's been exposures, whether it's environmental or prenatal, drugs, medications, too much smoke in the house. How do we mitigate these effects? Because putting everybody in a bubble and protecting them from life, God, if I could have done that already, it would have happened. So we have to think about, like, you've experienced this. How do I help make a difference in you going forward? So that harm reduction, these are the risks you're exposed to. How do I kind of pull that down? You're in a situation where we've got a lot more going on than just me being that encouraging face. Let's talk about cutting down on smoking. What are ways in which we can make interventions? So one of the antidotes to ACEs, when you've got all this stuff that's happened in your life and you're experiencing these things day to day, is resiliency. Is that something you guys talk about much? Resiliency? Yep. Like, how do you pull up that resiliency? Like, what have you got? And that's someone who cares, right? So somebody, like, you've got, like, did I spell that word right? You've got a family member, you've got a parent who's very invested in you. There's one who's off the rails, who's doing all kinds of crazy stuff, in and out of jail, whatever, total disruption in your family. But your mom, she's like, you know, she's got it. She's like the iron horse. She's there. She's solid. She's pulling everybody through the muck. She never sleeps. She works 3 jobs, but she's doing it. She's making certain you're cared for. So someone who's kind of like pulling you up out of that. Social connections, positive relationships, knowledge of parent and child development. So some of our parents, I'll be honest with you, them understanding like where your kid is developmentally and how to interact with that child and bring them to like how you support them through this phase or that phase, like trying to convince a mother spanking her 6-month-old because it's been bad is really not developmentally appropriate. So sometimes that's hard, but it's not like you have to get all of these to be resilient. Just one of them will make a difference. So for those parents who do like kind of get the idea, or guardians, that certain developmental stages mean certain ways of interacting with our kiddos. Social connections. It may not be your mom or your dad, but you've got a grandpa who's really invested in you, takes you fishing every weekend. That's one of these resiliency building factors. Concrete support in time of need. So like your parents, they can't do it. The guardian you have is kind of checked out. But when they come to your office, they have resources. They know they can come there because they're like 16 and they can drive, right? So they can come to your office. They can make an appointment. Maybe they have a thing that says they can be seen. Or they're like, you know what, I know I can be seen for contraceptive needs. It's totally not what I'm coming to talk about, but that's how I'm getting in the door. So they can be resilient. We can encourage that resiliency in them. And then social and emotional competence of children. This one I love, like when you've got a little kid and you're telling them, it's like, well, use your words, use your words. What words are they supposed to use? Like we have to teach them those things. Like, how do you feel? Do you feel angry? Do you feel sad? Do you feel mad? Like, teaching them, guiding them. So that's another thing that we can do. And you guys have wonderful support in your clinics to help. And learn those tricks yourself so you can put them in your pocket. When you're in the clinic where you think, you know, where's your craft? And they want to pull out the construction paper. That you've got some of those tricks in your pocket. And you can do these with your kids as well in your clinics. So this is, you guys have also probably heard about the Building Strong Brains program in Tennessee. This is a really pretty graphic from them. It just, for me, there's a bunch of words and colors. But really, it shows me that it takes a lot more than just one person. It's systems, it's teams, it's all of us working together across disciplines, whether that's, you know, pediatrics, family medicine, internal medicine, psychiatry. It takes all of us working together, and it also takes all of the other agencies around us working together to make a difference. So we are not going to do this all by ourselves. It takes many to get it done. So being engaged. This is soccer on the sidelines. How many of you guys have kids who do soccer? Yeah. Have you been there? You've been that person? Yeah, on the sidelines. So, so hanging out on the sidelines, you and all the other parents, like even though you're there as a parent, you are still a pediatrician. You still have knowledge and influence, and you can be a beacon to these other kids and their families. So even though you're like, I'm off the clock, I'm not at work. Guess what? It never stops. Just want to put that out there. It's really fun when you're on the sidelines and you realize, oh my God, when that kid gets beamed in the head by a ball, I am the only person who's actually qualified here to take care of that kid. That was me the last time I was on the soccer field. I'm like, crap, none of these people know what they're doing. They want to check his glucose. That's not the problem. So even though we have our jobs, we come to work, we shut down the computer, and we're done, we're not done because we have knowledge. So wherever we go, being those beacons. And then, of course, obviously in the clinic, when you're interacting with your adolescents, being open, being inquisitive, wanting to know what their lives are like. You guys do this whenever you do your well child checks. You know, what do you want to do when you grow up? What are your friends like? All the questions that you go through, they're super important. Sometimes it can feel pretty routine and rote, but it's actually really important because that individual, nobody else has asked them that question today or this week or this year. So those questions are important. And what they say to you is even more important because you want to remember that. And the next time you see them, you want to bring that back up. So did you get that internship you were hoping for? Like your senior project? Like you got it? Or what are you going to do for it? So re-engaging with them about stuff that you guys have talked about before. So all of these are like intervention strategies, right? So you kind of got the low kind of, you know, maybe you aren't being raised by your parents, you're being raised by a grandparent. But your grandparent's great, and you got all this good stuff going, and they take you to extracurricular stuff. It's really awesome. But maybe we've got a little bit more going on. You have more risks identified. You need more interventions. So getting them engaged with behavioral health, counseling staff. Maybe you're referring them out, and they're doing some stuff like play therapy. They're having, you know, group sessions up in the far. I'm not going to touch any more buttons. But if there was a laser pointer that I knew how to use, I would point in that far corner right there, like where you've got family counseling. So what is it that your family needs? What is it that your patient needs? Because your patient is part of a bigger picture, and identifying those other issues going on with the bigger picture is also part of how we intervene and make a difference and keep this kid on the right track. And then maybe we have to go another level higher. There's a group with Frontier. They do an intensive outpatient program, Adventure program, I think is what it's called. You guys may have referred somebody to Adventure program. Have you guys referred anybody to an intensive outpatient, any of your adolescent patients? So we do have that locally. This is an inpatient down in Knoxville. They actually have a school associated with it, which I find interesting.
Do they take Medicare?
I don't
That's
know.
all the insurance is listed there.
Yeah, I'm not certain if they do. I believe that Frontier for the intensive outpatient would. So psychosocial treatment, that's kind of what we went through. So we've identified, like, you know, maybe we have some risks. What ways do we want to intervene? Maybe it's just, recognizing the resiliency points that your kids do have, reinforcing those resiliency points, being some of that resiliency development for them ourselves when we see them in our clinics. I love coming up with other reasons to see kids. Like they're growing fine, they're up to date on their immunizations, but I just get the feeling there's something going on with you. Like, I don't want to wait a year to see you back again. You're only going to come back if you're sick. Like, how about we just check in 6 months and make certain you're staying on that growth curve? I don't know. I'll make something up just to bring them back. If I've got that fuzzy feeling in my head, like, I want to know more about you. I want to connect more with you. So I will find reasons to bring them back. But sometimes we do have to go the full distance and send them to an inpatient or an intensive outpatient facility because they do have some concerning use patterns. Like, unfortunately, I thought it was going to be so fun and interactive, and you saw nothing of what I was doing, where we were riding off the rails. Like, we were being wild and crazy and using just about any substance our hands came across. Like, that kid would probably benefit from being in an inpatient setting because somebody needs to push that pause button real hard for that kid. Some things we can take care of out in the world because really that's where they live, is out in the world. And pulling them out of the world is great, and then you put them back in, and they're re-exposed to those same stimuli, those same triggers, those same situations that got them to use and go off the rails in the first place. But sometimes it is just too much, too fast, too dangerous. We need to push pause and pull them in to an inpatient setting. So that's our psychosocial treatment. The meds. You guys probably thought I was going to start with this, right? We just talk about drugs the whole time. So that's kind of the next phase of this, like harm reduction. What are you doing? Well, let's try and do less of that because you're not really interested in doing anything else because you want to be cool with your friends and smoke a few cigarettes. Or, I've identified some risks. You're drinking on the weekends. I want to get you engaged in some therapy. You're drinking on the weekends and smoking everything, and next thing you're going to be shooting up heroin, so let's get you some inpatient treatment. But maybe someone is using their grandma's prescription opiates, and they're starting to buy them off the street, and maybe they're smoking too, and maybe they're using a little bit of meth, but predominantly they're using opioids. So there are some things that we can prescribe to treat. So we have a prescription as our friend, and we can help these kids out with some medications. The medications that are approved by the FDA to use in the setting of opioid use disorder: Methadone, Buprenorphine, and Naltrexone. Have any of you guys ever written any of these medications? Yeah, you wouldn't have or shouldn't have at this point in time. Because when you need an X waiver to write buprenorphine and methadone for opioid use disorder, you really need to be in a federally qualified facility, like a federally designated opioid program treatment facility. And then Naltrexone, that one is a maybe. You don't need anything special to write Naltrexone. But we'll talk about them in a little more detail. So if you look at Medicaid, because that's what a lot of our kids have, 76% of adolescents with the diagnosis, like somebody wrote it down in their chart and went through the Medicaid claims processor, and we see that these kids, this many of our Medicaid throughout the U.S. database, 76% of those diagnosed with opioid use disorder got any treatment of any kind within 3 months of that diagnosis. I gave you the diagnosis, and 24% of you didn't get anything. So 76% did. It's not a horrible statistic. But only 4.7 of that group received a prescription of any of those 3 agents. A lot of times adolescents are put through detox. So we're going to put you someplace, we're going to get the stuff out of your system, and then send you on your merry way. How successful do you think that is? Not really. That's a real good way to relapse. It's also a really good way to overdose because they took it all out of your system and tolerance comes back super fast. So it's actually a pretty dangerous way to treat kids who have an opioid use disorder. Detox actually isn't treatment, which is why it's in quotes. It's a process. And then you should be doing something after that. Like you need to engage in clinical, like social work, counseling, whatever. They need lots of wraparound services. And sometimes they need medication. The risks inherent in not treating opioid use disorder far outweigh the risks associated with using any of these medications. So are there risks with the medications? There's risk with every single medication we prescribe. And yes, there are risks associated with the 3 medicines I told you that we use for opioid use disorder. However, the risks of not treating far outweigh the risks of the medication themselves. All-cause mortality in adults is greatly reduced. So a lot of this, what we talk about, we extrapolate from adult data because we don't have a ton of data in kids. But when you look at adults, and a lot of them are young adults, and you look at all-cause mortality, if we treat, it's lower. And then 20-fold increase in early death for anybody diagnosed with opioid use disorder, 20 times the risk of early death. So risk versus benefit, you can kind of see which side we're coming out on, and I said it twice already. So methadone, really quick rundown on the drugs. Full mu receptor agonist, so this is one of the main players in opioid receptors, is the mu. This is the guy when we sit on it, provides the euphoria, provides the respiratory depression. So methadone is a full. He does it all the way, just like heroin, just like oxycodone. Again, it has to be in an opioid treatment program. I'm not writing this. This is not a drug that I write. And I really hate methadone, actually, so even for chronic pain, I would not write this guy. I hate it. But that's just me. Other people think it's a great medication, and that's where we have most of our studies in opioid use disorder treatment because we started using this guy in the 70s. The benefits, people stay in treatment. They have decreased opioid use other than the one they're being prescribed. Daily observed dosing. So you kind of have a captive audience. They keep coming to you every single day. You know they're taking their meds because they came in and you watched them take it. Structured programs with additional services offered. So they're going to get more because it's not just about the medicine, right? You need more. The medicine is a piece. There's so much more than you need. You need that social support. You need counseling. You need a home that you can go home to and be comfortable in. You need food on your table. I'm blocking your all screen. The risks. I already mentioned some of these. Respiratory depression, sedation. The potential for overdose with methadone is definitely there. QT prolongation. I'm going to say people in a second. Scarcity of age-specific pharmacokinetic and pharmacodynamic. Like we don't know. Like how we prescribe it for adults, like is that the starting dose, like 20 to 30 milligrams? Is that the starting dose for kids? I don't know. Nobody really knows what is the appropriate starting dose. We have it pretty well set for adults. Like we'll start them at 20 to 30 milligrams of methadone. But for kids, I don't really know. The other thing is they do daily dosing. Do they have somebody? Do they have a bus pass? Do they have a way to get to their OTP every single day? And if they don't, they're going to miss doses. They're going to withdraw. They're going to want to go back to use. Their risk of overdose goes up. So that can be problematic. Buprenorphine. This guy's pretty fun because he's a partial agonist, which means he sits on that mu receptor, just like methadone does, but he only partially activates it. He just kind of occupies the space. He will satisfy cravings, and he will make people quit withdrawing. You feel sick, you take your buprenorphine, you don't feel sick anymore. But it does not provide that euphoria effect the same way that methadone or heroin or oxycodone will do. And then it's got naloxone mixed in. So you can do a combination product, buprenorphine, naloxone, or buprenorphine all by itself. Buprenorphine, naloxone, and naloxone are our friend Narcan, right? So that's what it's mixed with. The idea is if you put it under your tongue or in your cheek, the only thing you're going to get is the buprenorphine, negligible amount of the naloxone. However, if you melt it down and you shoot it up, you are going to get naloxone. However, people don't want to feel what they don't want to feel, and they will shoot up Suboxone. They feel real sick, and then they feel a whole lot better because they will get 100% of an injected buprenorphine as compared to under the tongue, they'll only get like 20 to 30% of their dose. So people will abuse this medication, which is why I say abuse deterrent, because if somebody's going to use something to feel different than the way they feel right now, it doesn't matter, which is why you can go down any grocery store aisle and find a spray can and go sit in the parking lot and get high, right? Because you can get high off of spray paint. You can get in your garage and huff some gasoline. If people do not want to feel what they are feeling, they will find a way to not feel that way. So the naloxone being in there, it's there, hopefully. People are not going to shoot it up or stick it in weird places. But people do. And that's part of having that relationship with your patient. So like, what are you doing with your medicine? Do you seem appropriate or do you not seem appropriate? It's the only option that is FDA approved for those age 16 years or older. So it's actually approved in our adolescent group. Methadone and Naltrexone are not. So you can use this medication in the kids you see with opioid use disorder because FDA says yes. The other stuff is kind of like, well, maybe it's better than the risks. So you can use buprenorphine, according to the FDA, safely in kiddos 16 and older. Positive findings for those treated with buprenorphine, that they stay in treatment longer than just those detoxified. Again, we do not have a lot of studies in the adolescent group, so our numbers are small. So a lot of this is extrapolated. It's a lot like the practice of OB. We are not going to put these people in randomized controlled trials because maybe something bad will happen, so never mind. We're just going to go with what little studies we do know and see if we can't move from there. Decreased potential for overdose. It's a partial versus full agonist. Decreased frequency of intravenous drug use. And QT prolongation is less of a concern. A little bit, but less of a concern. Diversion and misuse, I talked to you guys about that. Unintentional ingestion by other members in the home. So if they got little brothers, little sisters, that can be a risk. So where are you keeping it? Because this is a take-home. You do not come every day and get dosed on this. So is somebody going to have oversight of this medicine, like a nice adult in your home who's not going to use it for themselves, and they'll actually give it to you? And then finding a waivered provider, because you have to have special certification to write this medication, who will also see adolescents. So I asked, our Overmountain, where they have methadone and buprenorphine, 18 and older. They do not see anybody younger than 18. Catalyst, who's actually run by the same individual who is the current medical director at Overmountain, they do see adolescents. I think they have one 16 or 17-year-old right now in their office. So we do have one facility that I know of, other than me, who will see adolescents for this. Naltrexone antagonist, it blocks. You can do it daily, or you can have an IM injection, and that will get you a whole month. This one's nice because you can kind of double dip. So if somebody's got issues with alcohol and opioids, this guy will do both. Not addictive, little risk of diversion. This is not a very high black market value at all. Possible improvement in treatment retention compared to those only receiving behavioral treatment. So what this does is it kind of tamps down cravings. It helps address cravings. But you still have to go through being sick, which is one of the risks and challenges with this, is that people often will not get through that detox period because you've got to be opioid free like 7 to 10 days minimum before you can start naltrexone. Otherwise, we're going to be looking at some precipitated withdrawal, which is ugly. Nobody wants that. All right, harm reduction, psychosocial treatment, medications. So you can see this little pyramid demonstrates, like, medications have a role, but it's not the only thing. There's a lot supporting those medications. Just medications alone are not going to get you the effects that you want. You're not going to see the change in the population that they need. So real quick, okay, 16-year-old, ward of the state, immigrant. She came to the U.S. when she was about 9. Exactly how she got here, she can't tell you. She did come with her mom and a bunch of other women. She lives in a group home. She's doing all right in school. She shows up in your clinic because she wants a pregnancy test. Do you guys do pregnancy tests? Awesome, good. So you give her a pregnancy test. You give her a go pee, and you come back and you're going to talk to her about the results. And when you're talking to her, you notice she has track marks. Go back one. So you're going to ask some questions. What questions are you going to ask? What is that on you? What's that from? What are these? Okay. Other things you may ask her. Yeah. So whip out your craft. Yell for your behavioral health person, please come help me. Okay. So do you think she might have an opioid use disorder? There's a lovely DSM-5 checklist for substance use disorder. Like, are you using more than you mean to? Are you having negative consequences? There's a whole thing. I'm not going to go through it with you guys. It's easy to look up. You can find it. You check it off. It's like, oh, yeah, I've got like 5 of those things. I have a severe opioid use disorder. So are we going to use MAT in this girl? Are we going to use one of our 3 medicines I mentioned to you guys? Do you think that's an option? There are a lot of things we need to know about her before we're like, all right, you get some buprenorphine. You have track marks? Buprenorphine. Great, good to see you. I'll see you in a week. Come back. So there are a lot of things you want to know about her. But I went fast through that part, but we do have some options to treat her. And then, because I just threw that in there, you're like, what? What? Human trafficking? Wait, what? Like that, if you didn't know the rest of the story, which I kind of know and I'm holding back on, she was 9 when she came to the country, Eastern European descent, She came with her mom. She has no idea where her mom is. She was living in a group home when she came for this visit. And she came with a bunch of other older women, about the age of her mom. So that's something to kind of think about. Because the environment that she's been in, she's been living in, she's a ward of the state. I mean, kind of the picture starts to fill in a little bit, right? But keep that in mind, because some of these patients we're seeing, they, just keep that in mind. I think it happens way more than we know about, because I think it's really hard to figure out. And if we don't think about it, we're going to miss it. So you're talking to her. You guys are having a nice conversation. You're engaging her, building that rapport, getting to understand a little bit more about what's going on about her. Like, maybe this is a harm reduction opportunity. Like, how often are you shooting up? Maybe you could shoot up less. Do you need access to sterile needles? Because maybe she doesn't want to quit. Maybe she doesn't want to say, like, I actually do have a problem. It's just something I do with my friends sometimes. So what are ways that we can help her be safer? And she came wanting a pregnancy test. So are you having unprotected sex? Yeah, maybe. So maybe we need to think about birth control. Maybe we need to think about STI screening. Maybe we need to think about a lot of things with this girl. She does want help. She doesn't want to do what she's been doing. She wants help. She wants to stop shooting up. As you talk with her and get to learn more about her. And you discuss with her the risks versus benefits of being in treatment, like what that might look like. Could you do intensive outpatient? Can you see a counselor? Do you want to do an inpatient, go for 28 days, 60 days, something like that? 2 months later, you guys had set up an appointment. She doesn't come. You wanted to see her about a week later. She doesn't show up. But you get a consult. She's in the PICU for an overdose. Do you guys see overdoses in your adolescence? And younger, probably? Yeah, yep. So you're kind of like, man, the boat left without me. Missed opportunity. But she's not dead. She's had an overdose. So scary. But you go to see her in the PICU. Talk about treatment options. She's thought about buprenorphine. And you start it. You can start it in the hospital. You can start it that day. You're going to bridge her. You're going to get her covered. You're going to get her into a treatment setting. You're going to get her a regular prescriber. Maybe that's you. I don't know. But you go ahead and get her started on buprenorphine. 5 weeks later, you guys can all read. It can make a difference. Engaging these individuals, getting them into appropriate care. Not everybody needs medications, but we need to think about it. We need to think about it. Because sometimes it is the right thing for your patient to get them on treatment, medication-assisted treatment. What kind of birth control would you give her? Mm-hmm. So are you guys placing Nexplanons? Perfect. Is anybody in your office doing IUDs? Just Nexplanons? Okay. So one thing, because like sometimes they're in your office. Can you do them same visit?
Yes.
Awesome. Because in my clinic I can't. So it's like I'm shooting you with a depot, and we're going to get that thing ordered, and we're getting it set up. I may want to talk to you all about how you get them in. Okay, at all times?
If you are done, then we have to order.
We have to wait. Okay, maybe I want to talk to you guys how you do that, because I want to know how you can do that. I'd like to place it same day. That would be nice. And she needs a sports physical because she's going to go out for basketball. That's one of the beautiful things about working with this age group. 5 weeks later, oh my God, she's like, I'm really cool and engaged and I want to play basketball. Like people's lives can turn around like that when they're 16. When they're 26, it's a little more difficult. But you've given this girl some more hope. Those are my resources. So part of why this is really important for you guys, you thought when I hit resources I'd be done, right? Sorry, I'm not done. I just keep on going. So this is a slide. It's from 2011 because apparently it takes a long time to process this data. I couldn't find anything more recent. But these are individuals aged 18 to 30 who were in inpatient treatment for opioid use disorder. Look at the age that they said they started using. Look at that. 11 or younger, 12 to 14, 15 to 17. That is the vast majority of people who I am seeing with opioid use disorder. They started in their teens. Pretty much without fail. It is rare that I have somebody who started in their 20s. So the time to ask, the time to intervene, because we all know early intervention is key, right? That's why we do breast cancer screening. We want to know before you have symptoms what's going on, because we can nip stuff in the bud. So that's why this is so important for the group of patients you guys are seeing. And then prevention, upstream intervention. Okay, and it's still not done. Shameless promotion. MAT half and half training, November 20th. You guys want to come? Please come. You can sign up for it on the CME website. And then, oh yeah, we got our ACGME accreditation. So if anybody are interested, because we do take pediatricians into our program and doing a fellowship in addiction medicine, come check us out. And I am done for real now. Thank you guys for your patience.